Good evening. We're going to go ahead and get you started here. Welcome to the In the Nose Ortho Seminar. It's our chance to introduce our new orthopedic team and give you some information tonight. I want to acknowledge real quick, we've got a couple other members of the ortho team in the crowd. Beth and Siv, raise your hands. Vicki Buchanan is one of our therapists. Our panel tonight includes Dr. Andrew Lawrence, who is our Director of Primary Care Sports Medicine, Andrea Marchi, who is one of our Director of Rehab Services, Dr. Matthew Baker, who is one of our orthopedic surgeons, Dr. Anthony McFerrin, who is not here yet. He got stuck in the office, so hopefully he will be here soon, and Dr. Charity Jacobs, who is another one of our orthopedic surgeons. My name is Jason Immenderfer. I'm one of the Director of Rehab. And I'm going to turn it over to Dr. Lawrence.
We on? Good. Good evening. Y'all are doing all right? Hopefully this will be informative, but succinct and concise, and get y'all's questions in, and like I said, get everything that we need to get across to you, but not keep you here all night either. So, like I said, my name is Drew Lawrence. I'm primary care sports medicine, so I was trained in family medicine and did a sports medicine fellowship. Volume okay? You're good. Okay. So I do non-operative orthopedics in addition to kind of the medical side of sports medicine. Part of my job is to make sure the surgeons make less money by keeping people out of the OR. Okay. So we're going to talk a little bit about what I do and how I do that, specifically as it relates to total joint replacements. A big portion of what I do, again, is non-operative orthopedic treatment. So we talk about conservative management for arthritis, whether it's low impact range of motion, over-the-counter supplements, over-the-counter medications, weight loss, specific exercises we can do to strengthen the muscles and soft tissue around the joints, that sort of thing. One of the interventional things that we do is ultrasound guided injections. And so a lot of people have heard of cortisone injections, steroid injections, that sort of thing. For certain joints, we need some image guidance to get there. So this is an example. Here is the hip joint injection. The hip joint is a deep joint. Would strongly advise against getting a hip joint injection without any kind of image guidance. It's going to be very difficult to make sure that you're in the spot. What we do with the ultrasound right there on the patient. I'm going to show you another picture right there. That is not a hip, that's a wrist. But it's kind of what it looks like. So if you have an ultrasound probe there, then you can imagine if that's on the hip, we see this. The ball on the top, the left side of the screen is the femoral head. That's the tabulum. The socket part of the joint is to the left of the screen. And if you squint your eyes and turn your head sideways, you can kind of see the needle coming down and actually get underneath the joint capsule. So again, we can actually see the needle, we can see the joint, we can see the needle going into the joint. A lot of times we can actually see the medicine flowing through the joint. No question that we're where we're supposed to be. So then, if the shot doesn't work, it's not my fault. We can do other things. We talk about cortisone injections. We can do platelet-rich plasma injections. We can do stem cell injections. Other conservative modalities. We talk about whether that's appropriate for you or not. I would just say a little bit of a word of caution to folks who are doing those sorts of things. There are some folks out there that are inappropriately treating with those things, so just be a little bit cautious. Okay. Another part, so that's a hip joint. Dr. McFerrin, I think, were you planning on talking about knees or hips? I got confused.
I'm going to talk about hips. Maybe
Okay.
hips and knees.
Okay.
I should be able
So
to
Dr. Jacobs may talk about both. Dr. McFerrin's talking about knees. Usually for knees, for most knee joint injections, we don't need an ultrasound. Sometimes we do just to make sure for certain things. There's another one out there called viscosupplementation or hyaluronic acid injections. If I'm doing the single shot injection of that, it's an expensive shot, so I use the ultrasound for that one shot series to make sure we're in there, similar type of procedure. Briefly, another aspect of it is diagnostic ultrasound. And so, just a little bit more pertinent for Dr. Baker's talk, he does mostly shoulder stuff. He's going to talk to you a little bit about total shoulder joint replacement versus reverse total shoulder joint replacement. So if you've got significant rotator cuff pathology, reverse total shoulder may be appropriate for you. And this is where I can help out with that, is if, particularly if you have some reason you can't get an MRI, you have a pacemaker or metal somewhere, we can do a diagnostic ultrasound. So this is an example of a torn rotator cuff. Yeah. So this is supraspinatus. You can kind of see, again, turn your head sideways and squint your eyes, this dark spot in the middle of the tendon. This is the rotator cuff tendon, this whole thing here. This bright white line right there is the arm bone, the humerus. This is deltoid muscle up top. So all this right there is actually a rotator cuff tear. I can see that on the ultrasound. If we see that, then we may decide that a reverse shoulder can be more appropriate for you. I believe that's all I've got right now. I'll be happy to take any further questions at the end of the talk, but right now I'll pass it over to Andrea.
Good evening. So as Jason introduced me, I'm one of the directors of rehab, and I have been a physical therapist for about 22 years and have seen a lot of people with arthritis and a lot of people after total joint replacements. So what I wanted to focus on tonight was the PT aspect of arthritis, and I thought we'd start with a little humor. So the cartoon says, next up, a story about something that's guaranteed to burn fat, tone muscles, beautify skin, improve memory, reduce stress, boost earning potential, enhance your love life, reduce the risk of every disease, and make you look and feel years younger. And she is all excited, and then the TV says, it's exercise. And she says, how far will the local news team stoop to ruin my evening? So this is probably what some people think, and if any of you have arthritis, you may say, yeah, that's exactly right. Every time I've tried to exercise, it's made my pain worse. But actually, people are sent to physical therapy when you have arthritis because we really want to be able to reduce that pain. So, the whole adage of no pain, no gain really doesn't apply here. So, that's part of what we do. That's really a lot of what we do, is teach you how to live better with arthritis, and definitely not to have your pain increase, but actually to decrease. So, if you see the doctor and he refers you for therapy, he's going to give you a prescription and an order for therapy. And it may be for a couple of different reasons, especially the specialists here that are with us tonight. They're either going to send you because they want you to be able to live better with your arthritis. They feel maybe a total joint replacement really isn't needed at this time, or it's not indicated. Or they might send you because they want or feel you need a total joint replacement, but maybe you're not really ready. So sometimes people need a little bit of a tune-up, or there's some things that we need to address before they can have surgery. So, and then of course, anybody who has total joint replacement, especially hip and knee replacement, is going to end up with some therapy. And that physical therapy will start in the hospital. So you'll have a short stay there in the hospital, but you'll work with the physical therapist while you're there. And then once you go home, you may have some home health therapy or outpatient therapy. Kind of depends on your situation, and that's something we can decide with you at that point. So, but no matter what the case, the goals for therapy are all about the same. And the number one thing, like we talked about before, is to reduce your pain. Most people, nobody likes to hurt. Nobody's really happy when they have to miss things that they want to be able to do with their families, or they want to be able to do their hobbies. And so it's one of the main things, and one of the first things we address is trying to reduce your pain. The next thing that we're looking for with that pain reduction is teaching you ways to live with arthritis. One of the things that you might already know is that you might not have any business doing everything in one day. So learning to pace your activities, and maybe you're not going to clean your whole house in one day, or you're not going to play golf in the morning and then go out to dinner in the evening. You have to learn to pace things. We'll teach you about using heat and ice and some other kind of home remedies to help you through pain, and just even talking about using a cane. That's usually people's not their favorite topic. People kind of look at us with a mean look when we talk about you might need a cane, but really, a lot of times it helps you and it allows you to be able to do more and with less pain if you have the appropriate assistive device. So, and then the meat and potatoes of therapy is working on your mobility. So we'll be doing strength training and range of motion exercises, balance exercises, all of the things that will identify your evaluation that can help you through to get better and kind of meet your goals for therapy. So, and the last one there is really to keep you safe. Sometimes the arthritis progresses, to a point where you really are unsteady on your feet, and either you're at a higher risk to fall or you're actually falling a lot. So that is, physical therapy has been shown to be able to reduce the risk of falls very well. That's one of the things we work with people every day on. And the things that we talked about was strengthening and walking and balance and such. That's really the bottom line of that is to try to keep you safe. So what does a typical session of therapy look like? Besides having a lot of fun and telling jokes and smiling, even though sometimes the session's not all fun, we'll do an individualized evaluation, meaning we're going to look at your medical history, we're going to ask you what's important, we're going to ask you, what hurts, when does it hurt, how does it hurt, what do you want to be able to do better? And through that evaluation, then we come up with a treatment program for you that's going to address the things that we've talked about. So the treatment, for instance, the balance workouts, the strengthening, the endurance exercises is all going to help you be able to be more independent, be able to do more during your day with less pain. So again, go back to the first, kind of one of the first slides where we talked about, are we doing this to prevent a surgery? Are we doing this before surgery? Are we doing this after surgery? Really the goals and what we're doing in therapy is all very much the same because we're just trying to make you be able to live your life better and with less pain. So the studies, research has shown pretty consistently that 6 to 12 weeks of PT has shown the best results. So my point to that and my point for you is that it's not a quick fix. Unfortunately, it's not like the injections that Dr. Lawrence gives. Sometimes you can get immediate relief from those injections. I don't have as much magic as Dr. Lawrence, but in the end, and if any of you have already had joint replacement, you know that all that hard work and everything that you went through to get stronger and improve your mobility, all is worth it in the end. So one of the things we do as physical therapists is we do a lot of encouraging and a lot of kind of just cheerleading you on during your sessions because it's not always fun going through pain and exercise and having to wish that you could be able to do more things today, but it's definitely all worth it in the end. So, and I believe that's it. So, I'm going to introduce Dr. Baker, and as Dr. Lawrence said, he's going to talk to us about shoulders and shoulder replacement.
Thank you, Andrea. Before I start, I would like to say thank you to all of our therapists, because they really are the cheerleaders. They really do, you know, the things that we can't do, that we don't have necessarily as bad as it sounds, the time to spend with you going over all the intricacies of your home exercise program, the function of the muscles, and just, like she said, being that cheerleader for you. So I would like to say thank you to all the therapists that help our patients. So, my name is Matthew Baker. I'm a orthopedic surgeon. I did an additional training, a fellowship in shoulder and elbow surgery, so that's kind of my niche, my real passion is treating the shoulders and upper extremities. And so I think the focus of this evening's topics is going to be more on the arthritis or degenerative conditions. And as Dr. Lawrence had talked about, doing the other things like injections, therapy, ultrasounds. So I'm going to talk a little bit more about joint replacements. So I'm sure everybody's familiar with somebody who's had a hip replacement or a knee replacement or have heard about those. And I think shoulder replacements aren't as talked about, mainly because they're not as commonly performed, and sometimes there just weren't very good options. So just to start off, little x-ray, little picture of what arthritis is. So arthritis is when you lose the cartilage or the nice smooth covering of a joint. And when that happens, you lose that space in the joint. And that can be a very painful condition. It can also cause loss of motion and decreased function. And that's multiple factors play into that. But a lot of it is because you're actually having a block. So instead of having space for that joint to move, it's kind of stuck in one spot. This is where therapy comes in, because if you can rehab your muscles and get some more motion, then the results after a joint replacement surgery typically are a little bit better. And so if you have shoulder arthritis like this, what are the options for it? Well, the two main options are what we call an anatomic total shoulder, which is where you replace the ball with the ball, and you replace the socket with the socket. So this is an x-ray here of a shoulder replacement where you have a metal covering right here, and that's replaced the arthritic bone, and then you resurface this the socket side with a piece of plastic. So instead of having those rough bones grinding on each other, you have smooth metal gliding on smooth plastic. So you can just kind of think your motion will improve, the pain will be better. Other things that you can do, you can see these stemless implants. These are a little bit newer technology, and they're a little bit more designed for younger patients who may have to have a revision later on down the road. And as Dr. Lawrence had mentioned, you can also do a reverse. And so a reverse shoulder is where you invert the components or reverse the components. You put the ball on the socket side, and you put the socket on the ball side. And that's what this x-ray here shows. And so this is the socket side, and you can see how the ball is there now. And on the arm bone, which used to be the ball, is the socket. And the reason that we do this is for patients with rotator cuff tears. Now, the rotator cuff is a stabilizer of the shoulder. When that rotator cuff is torn and cannot be repaired, you lose that stability of the shoulder, and that's why you do a reverse. It's a more inherently stable prosthesis or part, and so it provides those patients with rotator cuff tears and arthritis a much better option than historically was available. So those are kind of the treatment options. This is another picture here of a total shoulder replacement, or a reverse shoulder replacement. Just a little bit different view. This is looking at it from the front. So here on the shoulder blade, you can see the ball, and on the arm, you can see the socket. So that's, again, it's the reverse replacement. So the typical questions that I get asked are, when do I have this done? And the answer to that is it's unique to each individual. There's no x-ray or anything like that that will make me tell you you have to have this done. The reasons for having it done are pain and limitations in function. So if you've had pain for 2 days and you're still able to golf, you're not going to be getting a total shoulder, okay? It's truly, it's the end of the road for that joint. So you need to do everything that Dr. Lawrence can do for you, injections, you can do everything that Andre and all the therapists can do for you. And once all that has failed, then you come see me and we can talk about replacing the shoulder, okay? The second question I get is, how long am I in the hospital for? Typically after this, it's a day or two in the hospital. So, we do the procedure, you're admitted to the hospital, we make sure your pain's controlled, we have the therapist work with you, make sure you can walk around, get dressed, feed yourself, do all those things. And most people are out of the hospital the next day. Sometimes it's a little bit harder to control the pain, especially if you're on pain medicine beforehand. It takes a day or two to control that. And the other question that I get asked is, how long do these last? If you get a total shoulder replacement, 85 to 90% of people that have that replacement will have that same one 15 to 20 years down the road. The reverse is a little bit newer, so we don't have as much data long term, but we do have good follow-up at 15 years, and that's about 85%. So these implants do last a long while, and people do very well in terms of improving pain and improving function. So just to wrap up here, arthritis is where the joint wears out. The end treatment for that is a joint replacement. We want to exhaust all of the non-surgical management before we dive into shoulder replacements or any joint replacement. And the important things to think of beforehand is the better your function is before surgery, the better we can anticipate your function will be after surgery. So if you come and see me and I say you need to do some therapy beforehand, it's not because we're sending you to that PT, that physical torture. We're sending you because we're trying to improve your end outcome. So thank you very much for your time and attention, and I'll turn it over to Dr. Jacobs.
Hi, my name is Charity Jacobs. I'm also an orthopedic surgeon, and I did subspecialty training after my orthopedic surgery residency in total hip and total knee replacements. So my talk is actually going to sound a little bit like Dr. Baker's because I do a lot of the same thing. I just do it for the lower extremity, not the superior extremity. And I'm going to, do we have slides for this? Yeah. All right. I'm going to talk about total hip replacements today. So I was going to start my talk actually very similarly to Dr. Baker. When you come into my office, I always try to make a note, if you can, to pull up your x-rays so you can see what's going on. So on the right, you can see a fairly normal hip. And if you, sorry. Anyway, there's normally space between the femoral head and the pelvis. What's in that space is the cartilage. And just like Dr. Baker, I'm concerned with what's happening to the cartilage. Over time, on the right, on this picture, you can see on the right, or on the left hip, there is joint space narrow. And then, so that's actually fairly severe arthritis. And on that patient's right hip, there is even more severe arthritis. So that tends to feel, at that point, probably like a lot of stiffness, because just like in the shoulder joint, you lose a lot of your range of motion in the hip. You can cause a limp, and you can get pain. Classically, we think of hip pain as in your groin. You can get it all over up to your butt. If you come to my clinic and you have a fairly normal x-ray and you tell me my hip hurts here always, if I push on it, it's very painful, I can't sleep on that side, we're probably going to talk about a different thing that I did want to mention because I see it a lot of times. Show me what button to press. Which is, there's a bursa over top of this joint, and you can actually get greater trochanteric bursitis. So while Dr. Lawrence is absolutely correct, if you're going to have an intra-articular hip injection, you need some sort of image guidance. I do sometimes inject people who are having that pain on the side and they can't sleep and it hurts a lot, and to help get the greater trochanteric bursitis under control. I always tell people the injection is not the treatment for this. Andrea is unfortunately the treatment for this. It's long, it's hard work, but you have to do it if your greater trochanteric bursitis is going to get better. But when people come in like this, they oftentimes, at this point, people hurt, they're stiff, they have a limp, and they're ready to talk about what are the next options. I just wanted to show, just so you have an idea, this is a nice smooth cartilage surface, and over time with arthritis, you basically lose that. So your nice smooth cartilage is going away. So now you have this rough bone-on-bone situation that's painful, and what your body does to deal with that is it tends to actually create just a little bit of extra bone to stabilize things, which we call osteophytes, and your bone gets harder underneath. And that's a painful situation for our patients. So after we've kind of exhausted physical therapy and injections, for some people with very severe arthritis, I just sort of jumped right to total hip arthroplasty, and to be honest, because the injections don't have such a good long-term effect with somebody who has the kind of severe hip arthritis that I showed on the previous slide. So what we basically do is we remove the part of the pelvis that has basically lost the cartilage, and then we remove the top of the femur. We insert this femoral component right here. I'm going to show you a real live picture of what this looks like. Most of us are using ceramic heads. If you've heard a lot about metal bearing surfaces, I use a pink one.
I know. This is the one I grabbed. So this is what you get tonight. Sorry.
I appreciate that. Anyway,
I got
so
an eye collar.
I use a pink head, unlike Dr. McFerrin.
She's a girl.
But it's ceramic, and it sort of limits our metal problems that you may have heard about in the news. Then we have the same sort of plastic liner that goes into a metal shell. The metal shell gets inserted into the pelvis, and then that gets inserted into the femur. And that's what it might look like post-operatively. So that's a real life picture of the implant that I'm going to put in that has a pink head and supports the interior of Dr. McFerrin's. And then this is an x-ray of what it would look like post-operatively. And this is just some of we use a lot of measurements to help determine how these hip implants are going to work. It's certainly possible for us to lengthen your leg during a total hip replacement. I tell all of my patients that's possible. We are trying to make sure that the hip remains stable post-operatively, and all of this preoperative planning is meant to reduce the risk of that. And just as an overview, sort of that's what the normal hip joint looks like, a diseased hip joint with arthritis, and then the total hip replacement. And the post-operative plan for these patients is similar to Dr. Baker's. You're allowed to be weight-bearing as tolerated. If you felt like walking out of the operating room, that would be totally fine with me. Most people they're not really interested in doing that. You stay, generally speaking, overnight in the hospital for one night. Some people it takes 1 or 2 nights. And then we do physical therapy in the hospital, and a lot of people have physical therapy out of hospital. Most of the physical therapy for a total hip replacement is basically walking. Dr. McFerrin can talk about the therapy involved for a total knee replacement is a little bit more specific in trying to make sure that we keep the knee straight and we don't lose extension post-operatively. And I mean, it's one of the most successful operations done basically in any kind of surgery. So that's why I decided to do it for a living. I'm happy to answer questions later. And Dr. Anthony McFerrin will come up and talk about total knee replacements. Yeah? No?
Where he's got people with him.
Is that what I'm doing?
Back in black, AC/DC all the way.
So total knee replacements, I'll go ahead. Both of us do both total hip and total knee replacements. Basically, it's the same kind of problems with your knee. The arthritis is the same. We're looking at the cartilage surface wearing down the knee joint. And if that happens, we oftentimes, the non-operative treatments for that, we think about various types of injections. Bracing can sometimes be helpful. Oftentimes people feel that their knee is not very stable. They have pain with range of motion. We also give them physical therapy and anti-inflammatory medications. When we've exhausted those options, then we talk about doing total knee arthroplasties, which Dr. McKern is holding some implants if you want to see. Basically, we cut the bottom of the thigh bone, the femur bone, and the top of the tibia bone. And then we cement in implants, and there's a piece of plastic in between them that allows them to articulate smoothly.
There is no kneecap at that part of it.
Yeah, we do. Do you replace the kneecap all the time? I do as well. So we resurface the kneecap as well. There are some other options depending on, for some very specific populations where we can do just a portion of your knee. So we can do a medial knee replacement or a patellofemoral knee replacement. Those are special entities that we'll probably talk to you about if you're a candidate for. And the hospitalization is the same. Usually it's 1 to 2 nights. I think most people who had a hip and a knee replacement would tell you their knee replacement was a little bit more difficult than their hip replacement. Post-operatively for knee replacements, we spend a lot of our time concerned about extension. We'll tell you in the hospital we don't want you to have a pillow under your leg. We want you to keep your legs straight when you're resting because that's very important. If you lose that, it's difficult for us to help you get that back. And with the total knee replacement, we are concerned about keeping your range of motion so that you have a functional knee post-operatively. Does anybody have any questions? Yes, Dr. Karen.
Why'd you steal my coffee?
You didn't come up here. Yeah.
The anterior approach for the hip replacement?
So between Dr. McKern and I, we do all of the large approaches. I do anterior and posterior, and he does anterior lateral. I will go ahead and answer the next question, which is there are no long-term differences between those. If one of them showed itself to be vastly superior, we would both do all of that. But basically, we do the one that we feel most comfortable with and the one that we trained with.
There's actually 4 ways to get into it. Anterior, lateral, and posterior.
Which feels better?
When does
Which
it do
feels
all?
faster? Which feels faster? I thought anterior feels.
So there's limited short-term data that shows that you have a somewhat faster, you get rid of your assistive devices a little bit faster with an anterior hip. That goes back and forth in the literature. There's no clear consensus on that. All of these approaches have benefits and risks, and we sort of pick based on sometimes your anatomy, sometimes our training, what implant we need to put in there, and how we're going to approach the hip.
She's a little nervous, I think. I've done like 600 of these talks, so it's just nothing to me, so I made her talk longer. Sorry I'm late, but some of us had to work actually while these kids were playing, so. You know, I was in the office when a nasty injury showed up, so we ended up having to do surgery on it, so I apologize I'm late. She talked about hip and knee, I was supposed to talk about knee replacement, so since she kind of covered that, we're gonna go right into our Q&A session. I know, Jason, you introduced everybody already, right?
Yes.
Talked about their backgrounds and training and stuff. So I'm catching in the backside here, so I apologize. So that was a great question. We'll take some more just a second here. So knee replacements are all pretty much standard approach. Hip replacements, there's 4 different approaches, and as Dr. Jacobs said, it varies on your anatomy, et cetera, et cetera, et cetera. There are pluses and minuses to every single one. So if you came in and told me you want this approach, I can tell you why it's the best approach. If you told me you want that approach, I can tell you why that's the best approach. So there's really no difference, to be honest with you. Question, somebody had one. Yes.
I had total knee replacement several years ago, and it never really would straighten out. It always kind of had a bend in it.
Yep.
So anyway, I was referred to a doctor, and they gave me a shot in that knee.
Okay.
And then I found out later you're not supposed to really give a shot in a knee replacement. Well, anyway, to make a long story short, I had to have revision knee surgery.
Okay.
It was 3 years, the 23rd. Nothing but pain, swelling, and I want to know, the question I have is, if another doctor does something, why is it so hard for another doctor to treat that patient if they can help them? Why won't they? I want.
It's not a soup question, is it? You guys seen the movie Finding Forrester? That's not a soup question from that movie, so it's, anyway. So there's lots of things to talk about in that story right there.
Well, I'm gonna have to make an appointment.
So
with you, I
the first
guess.
thing we know for a fact from literature that knee replacements that do not go into full extension are the ones that have the most pain. There's no question. So that's why Dr. Jacobs was talking about we stress the extension right away. We want you at 0 within 10 days or sooner. If you don't get full extension, I will tell you that giving a shot is not going to help with your motion.
Tell me about
As far as giving a shot in knee replacement, I do it. It's not a problem. You don't want to do it often, but there's really no
it. When
contraindication
it
to it.
broke the fat down, there's such a thing as
Say what?
breaking the fat down in the knee. Is there
There's really
fat?
not a lot of fat in the knee after knee
Well,
replacement. There's very little
whatever
left.
it did,
So
it's,
you can get a thing called fat necrosis if you put the shot in the wrong spot. Subcutaneous tissues. Dr. Lawrence is not inside. You want to take that one real quick?
Yeah,
He's our injection guru, so
I was just happy you were answering that question, actually.
we hate each other too. You can't tell we do not get along at all in our office.
Yeah, I mean, that's a difficult situation, and the crux of your question is a difficult answer to, as far as injections into a prosthetic knee joint. I agree with Dr. McFerrin, we'll do it sometimes in the appropriate situation. One thing you gotta worry about is an infection as well, and the prosthetic joint, increased risk of that. There's always a risk of fat necrosis if you put a steroid injection, specifically a steroid injection in the wrong spot. Most of the time, if it's gonna happen, it's gonna happen in the Hoffman's fat pad, which is in front of the knee. That usually doesn't cause a whole lot of problems. Sometimes we'll actually do that on purpose if you've got something called Hoffman fat pad syndrome, where it's getting friction into the fat pad. So I'm not sure that the injection part of that is the biggest problem with the scenario that you just laid out. Sounds like to me the loss of extension was probably initiating the problem.
well,
There's lots of issues that can cause that, okay? And to answer the last part of your question about why is it so hard to get people to fix other people's problems, that is in and of itself a multifactorial issue. Number one, they take a long time to do, and most people don't do a lot of them. So there's a lot of literature out there that says if your surgeon does not do 50 or 100, depending on which study you look at, total joints a year, you have higher complication rate. The average orthopedic surgeon, believe it or not, was anybody at my first talk in January? Remember, they were 20. The average orthopedic surgeon does 20 joint replacements a year. That's it. I did 6 on Monday. So we do way more than that at our hospital. And these guys, once they ramp up, will be doing a lot more than that too. Dr. Baker's already done more shoulders in his 9 months here than he did a couple years in Festus because the population is just different here. So we get a lot more volume here. So if you're not comfortable with it, you don't want to do it. Number 2, it takes special training, to be honest with you, to do revision work. There are other people that can do it, and general orthopedic surgeons decades ago would have. Today's orthopedic surgeons coming out, this generation, and I'm not bashing this generation, just the way my medical training has gone to, won't touch it. That's actually my favorite surgery to do, is fixing somebody else's total knee that broke.
Oh, good, I'll make an appointment.
I actually designed a revision knee replacement that sells on the market today, so. if
Don't
you have-
take all the knee revisions.
Yes, sorry, you can have all the difficulty.
Well, I heard there
So
was a
failed total
recall
knees
on
are
Stride.
difficult. There's lots of different things that can happen with a knee replacement.
Yeah.
To fix the ones that are broke can be, you gotta know what you're doing. So there's just not a lot of people that like to do that because they're hard. And I think they're fun, and so does she. We're a little bit crazy. Somebody else had a question in the back, Jason.
This gentleman was asking about doing both knees at the same time.
Charity, you wanna take that? I don't do it anymore.
I would recommend against it. I tell almost every single patient that asks me that don't do it because it's a huge, like I said, a total knee replacement is a harder operation than a total hip replacement. So in my experience, almost all of those people have to go to rehab or basically a nursing home to recover for a period of time. The only people that would really ever talk me into it are some in shape younger people with bilateral severe arthritis who can't take off work. They have to be highly motivated and they have to understand this is very, very painful and likely to lead to a nursing home stay. So I advise almost everyone not to do that. And almost everyone I talk to in the hospital post-operatively is like, thank you. I don't want this done on both knees.
There's a lot of literature that says you should not do that. There are multiple studies that show, so if you have a complications rate of 2 in one knee and 2 in another, you think putting them together would be 4, it's not, it's like 8. it actually is an exponential increase in your complication rate doing both of them at the same time. That's one reason I don't do them anymore. Number two, doing one knee, we can control your pain pretty well. You can go home the next day, you get up and walk and do everything, and you're comfortable just roll narcotics. Doing both, it is a big shock because we can't do some of the medications that we would do with just one. We can't split it in half. Number three, insurance companies don't pay for your second knee. So if you have it done, the hospital gets $0 to do your second knee replacement. So most hospitals don't want you to do that anymore either because it's expensive.
From the therapist.
Turn your microphone.
So from the therapist perspective too, trying to do rehab on 2 knees at once is doubly not fun, especially in the very beginning. And not only are you dealing with 2 knees that hurt and not really a good leg to stand on, but your home exercise program doubles automatically. So I always tell people who have total knee replacements, this is your full-time job for the next month. This is what you do. This is what your day will revolve around. And if you had to do 2 knees at once, boy, you'd be doing a lot of overtime. So from a therapist perspective, it's really hard. So.
Yes, sir.
I had both knees done, and I know I wouldn't do it again.
Typically, I'll do one and do the other knee work 4 to 6 weeks later. You need both done. We can still get you back to work on your FMLA in 12 weeks without a problem. Yes?
I was wondering, do you do the physical therapy prior to surgery for a knee replacement? And is it the same as it'll be after the surgery, or is?
It is different. Dr. Baker touched briefly on that on shoulder replacements. If you have a frozen shoulder, the best predictor of range of motion is pre-op range of motion. Same with knee replacements. So there's a lot of patients who do knee replacements, physical therapy beforehand. Same with hip replacements. You have weak hip abductors, the muscles that pull your about the side. We want you tuned up as best as possible. And I always tell patients that it may delay your surgery by 4 weeks, but it'll increase your recovery by about 12 because you're in better shape to start with, so you recover quicker on the backside. Andrea, do you have any other thoughts on that?
The only thing to add to that, I would say too, is it does help to, you kind of know what to expect. You've spent some time with the therapist before surgery, and we've had a lot of time to talk in therapy, and so we can kind of help guide you as to what to expect. And you know, when you start your exercises day one in the hospital already, you'll be doing some exercises. You're not as maybe overwhelmed as you would be if you hadn't done anything before surgery. So even if you aren't sent by your surgeon for formal physical therapy before surgery, it's certainly a good idea to try to get a little bit better in shape, if nothing more than to try to get a little stronger and improve your endurance a little bit before you have surgery.
Plus, you get to realize how mean they really are. Other questions? Yes.
In hip surgery, does the patient have to be a certain BMI?
So the orthopedic literature supports that total hip and no total knee replacement patients should all be under a BMI of 40. I think the total shoulder literature is different. So I think that sort of allows a BMI of 45. And the reason is that the infection risks are higher. And when I have this conversation in my clinic, I always tell people what happens if a total hip or total knee, or I guess a total shoulder is infected, because you don't treat that with an antibiotic. You treat that with surgery. Either you take out the plastic liner in between in the hip or in the knee, and you hope that that is going to make it better. You get a semi-permanent IV line. You get 6 to 8 weeks of IV antibiotics, and it's 70 to 80% cure rate. The gold standard for treating that is actually to take you to the operating room and remove your entire joint to put in an antibiotic spacer to do that same semi-permanent IV line with 6 to 8 weeks of IV antibiotics. And when you have cleared the infection, if you do, take you back to the operating room and put in a more extensive total joint replacement. So if you want to meet the craziest people in our operating room with regards to infection, it's McFerrin, Baker, and Jacobs. We wear space suits, we do all kinds of crazy things. I heard you don't.
I'm just crazy anyway, so it's okay.
McFerrin are just crazy. But we do every single possible thing we can to avoid infection. So we are starting some guidelines at Southeast Hospital to help guide people who are good candidates for total joint replacements, and it's going to be BMI under 40 for people who are having total hip or total knee replacements, a BMI under 45 for total shoulder replacements, non-smokers, because smoking has also been shown to increase infection, and have your diabetes under control with an A1C of under 7.5, and didn't be off narcotics.
So we also have a program here at Southeast Health. So if we tell you that your BMI is too high, or hemoglobin A1C is too high, or whatever, there are certain criteria, your protein's too low, your this, that, or the other, it's actually for your benefit, okay? Because we can, again, almost like the rehab question, we can take some time to tune you up beforehand, and you have a much lower risk ratio, you have a much higher recovery ratio, and you have a quicker recovery too by getting tuned up first. So, did you introduce her yet?
I did not.
Would you like to, Mr. MC?
This is Raina Childer Richmond. She is a dietitian with us at Health Point, and
She's going to talk.
She can give you a little background on
We have
some of the
another program
programs
we
that
call
we
our
offer.
launch and other stuff. She's going to talk about that real quick here
Sure.
for you.
So there is
Put
a
her on the
movement.
spot.
Yeah, that's okay. I do this all the time too. There is a movement across the country to have people who are pre-surgical candidates get in better shape, improving their outcomes, and it's great to see that coming to Southeast Missouri as well. But getting in shape, including weight loss, is not an easy thing to do, especially if you can't move very much. So people often find they're really frustrated because they want to lose weight to get ready, but then they can't do much, so what do I do? Well, we have some more intensive programs at Health Point Fitness that we can help with, can help get you ready through nutrition, physical activity, and then some behavior modification classes that are targeted for the person who's ready for surgery. So surgery isn't imminent, it's the next thing we're gonna do for treatment. And so that program is called our Launch Program. And that program lasts 12 weeks plus, depending on how long a person needs or what their health goals are. If we're going from a BMI of 53, or if we're going from a BMI of 47, and we're trying to get to the goal of 40. We have just several different approaches that we can do to help. People who are involved in our weight management services also receive free membership to the Health Point Fitness Centers in both Cape and Jackson. And usually how the referral works is if you're a candidate for that, the doctor's gonna send you to our physical therapy department, and they're gonna do some evaluating, and they're gonna kind of start that prehab program, and then they're gonna send you over to talk to me or one of my colleagues. And then we'll go from there on the weight management side, really focusing on the nutrition, because although exercise is a big part of weight loss, we can do a lot more with calorie reduction than we can with physical activity calorie burn to lower body weight. So we have a couple options for that, and we're really excited that we have some champions here for weight loss, so we can give you the best outcomes for your surgical interventions. Thanks.
Thanks, Randy. Other questions? Yes, sir.
You said you did 5 hip replacements in one day? Somebody, okay.
Dr. McPherson,
Just
he's a little speaker than
talk
I
me
am.
through, I'm gonna need one. Talk me through, the person who, what time do you show up if you're number 1, and if you're number 5, what time do you show up? How long does it take to do it? And then number 1 person, when do they get out of the hospital? And number 5 person, when do they get out?
Well, it depends on how much you pay me, whether you go number 1 or number 5. I take food, as you can tell. That's fine. No, good question. So we don't actually set our own times, believe it or not. We schedule our cases, we send it over to the operative department, and then they schedule you what time to be here based on anesthesia, surgical techs, how many rooms do you have that day, what are you, what are equipment, et cetera, et cetera. I almost always have 2 rooms, sometimes I get 3 rooms. My total hips take me about 45 minutes to do hip replacement. My knees take me anywhere from 20 to 35 minutes, depending on what implant I use, and whether I'm doing what's called a pre-navigated knee or a non-pre-navigated knee. I've been doing this for a long time. Okay? I've been doing surgeries for 25 years or more. I've done probably 3,000 total knees and probably 1,000 total hips, if not more. So I always tell everybody it's like Midas, right? I can go change my own brakes and I'll do a great job. It's gonna take me 6 hours, right? Go to Midas and they're gonna do a great job and it's gonna take them 30 minutes because that's what they do, all right? So when this is what you do, you get to be faster at it. Typically, you're gonna show up 2 hours before the first case, or an hour and a half if you're the first one, which will be 6 o'clock. The case will start at 7:30. You go to the room at 7:30. We actually start the surgery probably about 7:50 to 8 o'clock, depending on how tough you are to put to sleep and they need this, that, or the other done. I'm out of the room by 8:45, and I'm going into the second room. The second patient's going in the second room, going to sleep while I'm finishing up the first one, so we can bounce back and forth that way. I have Siv stand up, put you on the spot. Siv is my nurse practitioner. She's in the OR with me. She's helping me. She's putting your dressings on, closing your wound up, doing that kind of stuff while I'm starting the second case. She comes in and joins me, and we just kind of run through that way. If you're the fifth case, if it's a total knee day and I have 2 rooms and I have the right OR techs and the right equipment, we'll be done with 5 or 6 total knees by 1 o'clock in the afternoon. And you'll be up on the floor by 1:30. If you are the first patient or the last patient, I round at noon the next day because they do physical therapy in the morning. Our inpatient, Vicky is here, right? Yeah. So our inpatient physical therapy will come around in the morning. There's no point in me seeing it at 7 o'clock in the morning because they haven't been into work with you the next day, so we don't know what you're doing yet. So I wait until lunchtime to come over at lunchtime, see how you're doing. If everything's good, I discharge everybody at lunchtime. Some people, I don't know what percentage will actually do afternoon therapy with you, half maybe. So about half will leave right at noon, the other half will go through another course of therapy in the afternoon and then leave at 4 o'clock or whatever.
Oh, so you spend the night then?
You spend one night.
Okay.
You don't have to, you can do it as an outpatient if you want. In Virginia and North Carolina, where I was at before here, about 15 to 20% of my patients do it as an outpatient, go home at 6 o'clock at night. Down here, I'm not hitting takers yet. It's just a different cultural mentality. I mean, we fought a lot of cultural stuff when I came here about the way things used to be done here. So we're trying to modernize things around here. So.
What is navigated knee? When you said if it's pre-navigated knee?
Yeah, there's different ways you can do knee replacement, and actually hip replacements as well. You talk about hip, I'll talk about the knee.
Okay.
So there's different ways of navigating a knee too. So you can do intraoperative navigation for knee replacement, where we actually either drill holes in your thigh bone and shin bone and put these little reflective balls that have infrared sensors, and there's a computer in the corner, and as I'm moving things around, I look at that. There's an artificial pressure sensor that I can put in your knee, and I can move your knee around after I've already put your parts in and look at that and tell me if one side's balanced or not, whether I need to release this side or the other. I don't do any of those. I do what's called a pre-navigation. So I take an MRI of your knee and a full-length x-ray. So I take an x-ray of your hips, your knees, and your ankles so I can see how curved you are in the legs. And then I send that to a company and they make a custom cutting block for you. Not custom implant, a custom cutting block. In that cutting block, all of the alignment is done in that block. The flexion, extension, in and out, up, down, et cetera, et cetera. So you can put a knee in right or left, up or down, front or back, twist it clockwise, twist it counterclockwise, and then the kneecap you can do the same. And the shin bone, you can do the same, right? So when you look at all those different things, we call those degrees of freedom, there's over 6 million positions you can put a total knee in. And by doing this custom navigation, it puts all that stuff in the right spot. So it lines everything up for you. By doing that, we also don't stick a rod up your thigh bone or down your shin bone, so you have a little bit less blood loss. It's a quicker surgery, quicker tourniquet time. We did one 18 minutes 2 weeks ago with the pre-navigation stuff. Without the navigation, it's about 35 minutes. So it's still not horrible surgery, but that's kind of how you navigate the knee. Charity's working with the hospital to get some navigation in for hips. So you want to talk about hip navigation?
There's similar things we can do to navigate a hip. Dr. McFerrin was referring to, there's various robots where you use arrays and you basically mark points in the bone, and then the robotic arm will go in and you sort of drive the arm, but the arm won't let you move outside of the appropriate place, and it reams the acetabulum like that as well. We're actually looking at some different navigation tools. So like I showed you, I just wanted to show you the preoperative templating. So we're looking at how long your legs are, how far your legs are apart, and making decisions about what kind of implants we're going to use. And then in the operating room, we have a special kind of x-ray machine that measures basically how tilted up your cup is, the cup we put in and how tilted forward it is. It tells us how much we've changed your leg length and how much we've moved your legs further or closer together.
And Dr. Baker can do the same with shoulders. You want to talk about shoulder navigation a little bit?
So yeah, similar to the hip and knee, we take a CT scan before surgery. It gets all the measurements, how much your socket's tilted, if you have any bone loss, and then various companies can create a guide that we base all of our pins and reamings off of. A lot of the literature shows, even in the people that are developing the implants, freehanding positioning of pins is still not very reproducible, meaning they train the exact same way every time and they're off by 5 or 7 degrees each time they do it. And when we use these guides, it takes that fiddle factor out of it, so it makes it very reproducible, and it just makes it more efficient. And lower OR times have been shown to contribute to lower infection rates and less complications. So anything that we can do to facilitate a efficient procedure, it makes everybody happy at the end.
And this navigation stuff, to be honest, has not been around long enough to have long-term data. We can't tell you 30-year results with it. The early indications on certain systems say it doesn't really matter. Other systems says it does matter. And when you're talking 2 or 3 degrees, it doesn't sound like much, but in a total shoulder, especially some of the reverse shoulders and things, 3 degrees off can make your shoulder last 5 years or make your shoulder last 35 years. I mean, there's that much of a difference just from that little bit of a change in position. So there are a bunch more questions. Yes, ma'am. I'll come to you back in a second, sir. Sorry.
I know on some of this stuff, like I'm looking at possibly a knee, but you're talking about having to do MRIs.
You don't have to.
Oh,
It's an
I was
option.
gonna say, because like I have had back surgery, so I have this metal in my back.
Not a problem.
Okay.
Yeah. You can't have an MRI if you have a pacemaker, an automatic implantable defibrillator, or if you had a stent within 12 months. But other than that, most hardware in your body really doesn't affect MRIs anymore.
Oh, really?
Yeah.
Okay. I didn't think you could have an MRI once you had.
We'll have to part you out because they'll rip your spine out. No, it really, most of the time, it does not matter. You can actually MRI your knee after a knee replacement. If you have a knee replacement, you need an MRI, look at the tendon for whatever reason, we can do it.
Most folks aren't going to MRI your back again, just because there's so much artifact from the hardware
Right,
that they
yes.
can't see anything, but it's not dangerous.
Right, okay.
Yes, sir, you in the back, blue shirt in the back row.
Although we're hearing about opioids, what kind of medications do you give a patient post-op and then when they go home?
So it's a great question. So I tell everybody that I came up with a technique, gosh, 15 years ago, probably 20 years ago, something in the neighborhood, and I call it getting better fast, and it's functionally accelerated surgical technique. And that actually starts in our office. I start with me telling you that you're not gonna hurt when you're in my office, and I'm not lying to you, because you're not gonna hurt right after surgery. There was a study done long before these guys were ever in college, let alone high school, where they did the exact same surgery on patients. Knee scope is what it was. They did a partial meniscectomy on 100 different patients, and on 100 patients they put little tiny dressings, and on the other 100 patients they put big bulky dressings. Guess which patients hurt more? Big bulky dressing, because they thought they had bigger surgery done. So a lot of it starts right here. So I started working on this one, you in my office, to tell you that it's not gonna hurt that bad, because it's really not. You're gonna be uncomfortable. I tell patients you're gonna hate my guts for about 4 days. Then I'm an evil human being for about a week. And I'm just kind of a mean guy for another week, and then at week 3 you love me.
I'm still waiting for week 3.
Yeah. It's been 9 months now, Drew, come on.
Me too.
4 months. Ask my wife, it's been 30 years. She's so, in surgery, there are different things we can do. A hip, you can't block. You can't really do a regional anesthetic block in the hip. They're very difficult. You can do a spinal, but they wear off really quickly. In the knee and in the shoulder, we can do regional blocks. So anesthesia will take an ultrasound and find the nerve that does your knee or the nerve that does your shoulder and put some numbing medicine in there. That will help you after surgery, because it won't completely shut it down, but it'll knock it out a lot. Then I also use, it's an injection. I put it in surgery. It's had 50 million different names depending on what hospital I'm at, from Love Potion number 9 to Farron's Magic Potion to joint juice to whatever. But it's also more medicine that we inject in your knee. And I have a vast majority of my patients that look at me and say they have less pain day 1 after surgery than they had when they come into the hospital. All right? Now here's the kicker, that wears off. Day 2 stinks. I'm not gonna lie to you, day 2 is not a lot of fun. But I don't use any IV narcotics. I have not used an IV narcotic on total joint patients since 2004. I use Toradol, which is an anti-inflammatory. I use gabapentin, which is a nerve-mediated pain agent. It's not a narcotic. I do use Norco, which is an oral narcotic if you need it. But I don't use any IV narcotics at all. There's the old PCA pumps you guys might have heard about before, where you push the button and people sit like this all day long, push the button, trying to get going on narcotics. The secret to those is It doesn't matter, it locks itself out, so you push it all you want, it's not gonna help. But there have been multiple studies that with that technique, that they actually have less pain. Interestingly enough, when you look at the literature, Motrin and Tylenol actually work better for pain relief in double-blinded studies than Percocet does. But everybody's got in their head that Percocet's the only way to go. It's not. I use Percocet every now and then, but not very often. And that's if you're allergic to something else. So we try to limit our narcotics. We're all different. Everybody's got different pain management protocols up here, but you're not going to come to our office and get prescriptions for Norco for 6 months. If that's what you're looking for, it ain't going to happen in our office.
This is one thing I agree with Dr. McFerrin about.
One thing. What do you do with these young kids? I tell you. We had a sign in the cardiology office at our hospital that said 120 years of experience. And I thought, this is great. I'm going to bring this back to my office because I've been doing this since 1999, right? And I looked and went, 26 years. Counting residency. Ooh, 2 years. We've got 26 years. Didn't work so well in our group. But go ahead, Charity, sorry.
No, I just totally agree. We are trying to get away from using opioids, and there are other medications that are more effective with less side effects.
Do you give brownies?
We take brownies.
Sure.
What kind of brownies are you talking about? Like CBD brownies, or?
Is that what they're called? I just don't do regular brownies. I know they release.
Where did you buy these brownies? How did you buy afterwards? Did you buy Doritos afterwards? Because if so, don't eat those brownies again.
Actually, what I don't know doesn't hurt me.
Back row, Jason, yes, please. He's been had his hand up forever.
I have a quick comment and a brief question. I'm a long distance runner, and first of all, I want to say kudos to SoutheastHEALTH Rehab and Therapy, because years ago I tore meniscus in not one knee, but 2 knees, and therapy and rehab worked perfectly where I avoided surgery, so thanks. My question is...
I just paid.
My question is just simply this: as a long distance runner, it always seemed counterintuitive to me, ironic, that the more I train and the more I run, it's less painful. So for example, this past March, I did my first ultra, and I ran 45.25 miles.
Why? I don't like to drive 42.5 miles, let alone run it.
I lived at the end, but I felt less discomfort than I did for 5K. And the context is I have severe arthritic big right toe. And my question is, why do you feel less pain the more you work out, the more exercise, more training, than you do if you did less?
Dr. Lawrence, right up your alley.
That's a great question. It kind of goes back to what we talked about before. So that low impact range of motion, obviously 42 miles is not what I call low impact, but joints like to move. Kind of goes also to what I call crazy. What these folks were talking about, getting you moving after surgery, keeping your extension, keeping your range of motion. Joints like to move. The more those joints can move in an appropriate manner with the appropriate flexibility, the strength of the muscles, the tendons around them, and move that joint efficiently. Joints tend to hurt more, not because they're moving, but because they're moving inefficiently or the wrong way. Sort of a little bit of a tangent, but we talk about treating labrum tears in a shoulder or a hip. Labrum is the cartilage, one of the cartilage pads inside the socket of the joint, and we've kind of gone one way than the other extreme, but anyway, we've learned that surgery is usually not the right choice for labral tears.
Says the non-surgeon.
No, he's right. And so we actually treat that by treating the muscles around it, the rotator cuff. And so what I explain to folks is if you've got a bad rotator cuff and your ball and sockets, every time you raise your shoulder, it slides around like this. Well, that's causing a lot of shear forces, causing a lot of irritation in the shoulder joint. If we can get that shoulder joint moving efficiently like it's supposed to, then the labrum gets calmed down. It's not feeling that shear force. It's feeling really good. So the same thing kind of happens with your cartilage, actually. If everything's working in concert and efficiently, and that joint is able to slide like it's supposed to, then the capsule gets loosened up and the fluid gets moving like it's supposed to and actually feels better.
I use analogies a lot, and what Drew said is a perfect one. Y'all car people in here maybe, I don't know, but if you got a bad ball joint in front end of your car and you have a bad tire, that's a bad combination. But if you got a good ball joint and bad tire, you can keep on driving for a long time. So that's the ball joint.
Did you go to PT school before med school? Because that's, was a really
You
good.
didn't go to med school, what are you talking about?
The only thing I would add to that is, you like to run. Obviously, you're gonna run that far, you like to run and you enjoy that. And, your body's probably creating some endorphins too. So, it's the feel-good stuff that our brain secretes. So that might be part of it. For most people, the kind of adage we use is movement is medicine. So that is true when it comes to arthritis. But 42 miles is a lot, especially with advanced arthritis. So kudos to you.
In the old days, 20, 30 years ago, it was if you had arthritis, you put grandma and grandpa on the front porch in the rocking chair with a shawl around their lap and told them to live with it. And that's the worst thing you could have ever actually done. The more motion is better. It helps lubricate your joints, help keep your cartilage from degrading quicker, all that kind of stuff. So, yes, sir.
If you have a predisposition with blood clots, either diabetes or something like that, you're on medication, and what's the procedure that you all do to kind of get you ready for, say, a shoulder or something, to get you away from, I have blood clots, obviously, and I'm on blood thinner and things like that, but in order to get you ready for an operation.
I can take it over. Go ahead. Go ahead.
I was just gonna say, if you've got risk factors like that, we're gonna try to maximize your non-operative, more conservative modalities. And so again, just kind of taking the spotlight off them for a second if I can. But I think they would agree, risk factors for surgery are called risk factors for a reason. So we're gonna try to minimize your risk of harm. So all the conservative modalities that we talked about already, and then, just to kind of take it a step further, for steroid injections, I don't require you to get off your blood thinners at all. For those PRP or stem cell injections, depending on what blood thinner you're on, as to how long we can take you off of, that sort of thing. And then I would kind of speak for them a little bit, that as a primary care doc, also, they're gonna talk to your primary care doc or your cardiologist or whoever prescribing the medicine, and be in close contact with them as to what's the safest thing for you, because there's different, obviously different reasons that you got a blood clot, whether it was just, what we call, provoked, you had trauma or prolonged inactivity or whatnot, or you've got a coagulopathy that you're really high risk for blood clot. Those are two different scenarios.
Completely different scenarios, yeah. We always check with the cardiologist or family practice doctor. Most of the time, to be honest with you, we can take you off for 3 days and you're fine. Put you back in line, the same one after surgery. Yeah.
I just had a little one follow-up. There was, a few years ago, there was this was a injection. Believe it or not, it was turkey.
Rooster comb.
Yeah.
Hyaluronic acid.
Yeah, that was
There's
arranged
7 of
for
them
a
on the
time
market.
for either knees or shoulders or something, they would inject that. Is there any benefit to that at all?
That's hyaluronic acid. It's only approved by the FDA for use in the knee. Most of them, I think one now has an injection in the shoulder. I think they were getting approved. I don't know if it went through or not. But Drew's our injection king. He can talk about that.
Yes, sir. So the literature on that is mixed, and the literature, in my opinion, the literature that says it does not work is mostly when they group all of the different brands together. I think there is some good evidence for the more native hyaluronic acid based models. So your knee joint, your joints naturally produce hyaluronic acid, and so the synthetically produced brands that look none of them look exactly like it, but the ones that look most closely like it seem to have better literature that they work better. The ones that are further apart, I think, work less. There's also some of the ones that have a single injection versus injection series. Again, what I'm saying here, I think, is debatable, but it's my opinion on review of the literature and also my experience, is that the single injections are less effective, and I think that's because we used to think that we were just lubricating the joint, right? We thought it was called an oil shot, lube shot, rooster comb shot, had 30,000 names to it. And we thought we'd inject it in, and it just kind of made things slide a little bit easier, slicked it up, and that's why it worked. But it turns out it worked for 6 to 12 months in a good number of people, and then they actually studied it. It's going in a couple of days. It's out of the knee joint in a couple of days. So that didn't really make sense. Then we found out later, well, we meaning people smarter than me studying it, that it actually hits certain receptors in the knee joint that decrease pain. And so my philosophy is more is not necessarily better in this instance. If you, the one-shot series is taking the 3-shot series and just putting it all on one syringe and injecting it at the same time. And so I think the subsequent contact of that medicine with those receptors over a few-week period actually does better than the one-shot series does. I think there's still a role for it. Insurance companies, unfortunately, are stopping paying for it, some of them, because insurance companies don't pay for things if they can help it at all, and there was some literature out there saying that it's not effective, and so some of them are backing up. I still do it in the office, for sure, if your insurance will cover it. That's one of the earlier things that we do for you.
Okay.
What's interesting with that is hyaluronic acid injections came out about the same time PRP hit. PRP's been around for 20 plus years, 28 years, something like that, early 90s.
Started with cardiology, actually.
Yeah, and insurance companies still consider PRP to be experimental, but they paid for hyaluronic acid injections forever since they first came out. But the literature actually shows that in most cases, not all literature, as Drew said, it's mixed and varied, but PRP injections actually work really well for pain. They work better than HA injections.
Better
but
pain
insurance
and
companies
function.
won't pay for those.
Better pain and function in 6 and 12 months compared to steroid and hyaluronic acid.
Thank you.
Yes, sir.
With the different knee injections, how do you tell which one's best for your knee, and how long do they usually last?
Between a steroid and hyaluronic acid, or amongst the different brands of hyaluronic acid?
Either way, different methods.
I always start with a steroid injection in the knee first. It's cheaper, it's easier to do, and for most patients it works really, really well. If they work for you, I will do hyaluronic acid. If the steroid does not work, I will really try to talk about an HA injection. Because in my personal experience, if the steroid doesn't work, the HA is not going to help much. Or got any thoughts, Charity?
Oh, that's my else thought. No? Okay.
I don't have any life of experience to.
So again, being a non-surgeon, I try more conservative stuff if I can help it. I do agree with Dr. McFerrin for the most part. If your steroid injection didn't help at all, HA injection is less, I think it's less likely to help is your, whatever pain generator you're having is not getting calmed down by, basically topical intra-articular medication. With that said, sometimes steroid injections help. They just didn't help that much, or they didn't last long enough. We call a successful steroid injection lasting an average of 3 to 4 months. So if it only lasted 6 weeks or something like that, we may not do steroid injections. We may change to HA injection. With that said, more and more evidence out there that steroid injections, both the steroid itself and the local anesthetic that great majority of us mix in with the steroid can be damaging to the chondrocytes, the cells of the cartilage. In our office, we use ropivacaine, so lidocaine and marcaine have been the most damaging to the chondrocytes. We have switched to, since these studies have come out, we've switched to ropivacaine, which is much less chondrotoxic. I use Kinalog, they use betamethasone, so different steroids, but the steroid over time is probably going to still damage the joint and cause advanced arthritis, or hasten the advancement of your arthritis. So I actually try to get you off steroids after a few shots if we can, 2 or 3 shots. It kind of depends on the scenario, to be honest with you. It's a long answer to maybe not a real long question, but if we're talking about, we know you're going to have a knee replacement in 18 months, you're going to retire, or there's something, you just got to get to 18 months. I'll inject the crap out of your knee with steroid until that 18 months, because you're going to get a new joint anyway. It doesn't matter if it damages, right? However, if you're 36 years old with early arthritis, I'm going to limit the amount of steroid I'm putting in that knee joint as much as I possibly can. We're going to try to go to other stuff because we don't want to damage the joint any faster than we already are. So that's an instance I would jump to HA injections much, much quicker, and then actually try to talk you into PRP or stem cells much, much quicker, because I think we can preserve your native knee joint, which I think everybody's going to agree is going to be ideal, and then prolong the need for a knee replacement.
Do you do a stem cell here also?
Yes, sir.
I was just gonna say that the answers that you hear up here what I take away from that, what I hear from patients is, you know, what worked for your brother or your sister or your cousin or the lady down the street may not be what's indicated for you. So that's why you go to see these orthopedic surgeons and the specialists in their field, because that's what they went to school for, and they're trying to do the best for you. And it may not be what was best for your sister. The same thing is true with therapy. Try not to compare yourself to your friend who just had total knee replacement or total hip replacement, because everybody's situation and story is different, and you just need to worry about getting yourself better. So day one and move from there.
I'm going to soapbox here a minute since you mentioned the word stem cells. Dr. Lawrence does them, Dr. Jimmy Bowen, who raised your hand there, Jimmy, just signed a contract to join us here this week, so he'll be starting in December with us. They both do stem cell injections. All right? That is the probably most overhyped, overmarketed thing in the sports medicine orthopedic realm in the last 10 years. There are people that are doing stem cell injections and PRP injections and all this other stuff and charging thousands and thousands of dollars, more in the bigger cities. You know, there's nobody around here doing this yet. Well, ever, hopefully. But for stuff that is not indicated, patients that should never have those injections, they're injecting patients with stem cells that aren't even stem cells. In the United States of America, the FDA regulates what you can call a stem cell and what you cannot. And there are people advertising stem cells that are not injecting stem cells. It's false advertising, plain and simple. Stem cells are great. They work wonderfully for certain things. But if you have bone-on-bone arthritis in your knee joint, and you go see somebody in St. Louis that I won't say his name right now, he will inject you with stem cells. And 3 months later, you're gonna come back to me and say, that didn't do a darn thing, I'm out $7,000 to my total knee. Okay? If you fly on airplanes, it's where I first noticed it was on airplanes, in the little magazine in the front seat pocket, you pull it out, and there's all these pictures of these people that are, their knees are like this, and they can't walk, and then the next thing it's them running on the beach like this after stem cell injections. That's hocus. That's not true, okay? You're not going to take bone-on-bone x-ray, inject 1 dose of stem cells, that's probably not even stem cells, to be honest with you, and grow new cartilage so your knee looks totally normal on x-ray and looks like it's 16 years old again. That does not happen. And as you can tell, that honks me off, and this makes me madder than a hornet right now with this stuff, because there is some individuals not too far from here that inject stuff that just drives me nuts. Injecting knee joints without an ACL and without a meniscus because they think that will help. Well, fixing the meniscus and the ACL, that will help. Okay? I don't know, what's the average in a BMAC? Well, how many stem cells are in BMAC? 4, 10, 20? Depends on your age. Depends on your age.
Actually, that's been shown recently not to be true, so you can even have it at 75 and 80. So we used to think after 65 you didn't have a whole lot of them. But there's hundreds of millions, potentially, stem cells, and there are places where they will grow them and expand them during the day. What doesn't have any stem cells in it, your own bone marrow and your fat has stem cells. What does not is when you go get amniotic fluid injected, and they advertise it as stem cells. There are growth factors, and there is one product on the market that the FDA has given a designation that it actually could help with early arthritis, and that's something called Mdl Fix, and it is actually just growth factors, and they're extremely expensive.
And it's early arthritis, it's not bone on bone. So go ahead, Drew.
Oh, I was just, Dr. Bowman and I were actually just talking today about this topic and kind of saying how we've talked more people out of this than into it. So I agree completely with that. We've got to be very judicious with who we're injecting and what the indication is and all that. And I also agree completely that if you've got severe bone-on-bone arthritis, I'm absolutely going to talk you out of any kind of orthobiologic. Orthobiologic is a term we use for kind of PRP, stem cells, amnion, all that kind of stuff. So, yeah, agree.
I'm very passionate about this because I always tell hospitals and stuff, you can screw me over all you want, but never mess with my patients. If you harm my patients, I will not like you. And we've hired, fortunately, this crew here is the same way, so we're very patient-centric. It drives me nuts to see people come in and spend that kind of money when I know it's not helping them. All it did was make the car payment for somebody's Mercedes in St. Louis.
And as he said, it's not covered by insurance, and the folks that are doing this are praying that it doesn't ever get covered by insurance because you know, they can charge whatever they want to and get cash for it, which is a problem, obviously.
When you have somebody over here.
There's one back here first.
Where? Jason?
Right
You
here.
got one? Okay.
I wondered about the effects of nicotine on the healing process of a replacement.
Horrible. And it's bad, you should not smoke.
I mean, there are some doctors that won't do surgery. And
So, especially in the shoulder, the nicotine, whether it's smoking, chewing, vaping, however you want to take it in, gum, patches, it acts as a vasoconstrictor. So you need blood, which has all the healing nutrients to heal your joint replacement, your rotator cuff repair, whatever it is, even the incision to get there. If you're a smoker, a chewer, a nicotine consumer, it increases your risk of infection, it delays your healing, it increases your risk of complications, your risk of blood clots, your risk of pulmonary embolism. So, you know, it's not something that should be in the setting of an elective surgery.
There are physicians in the big cities, like you said, that will not do it anymore. Period. If you're on tobacco products of any kind, people can't do surgery. They actually test you for nicotine the day you walk in the OR for your surgery. And we're real close to doing that too.
Does that include secondhand smoke or just?
Secondhand smoke too? It's not as bad, but secondhand smoke, so.
Does that
you know,
actually
the
show up
FDA
in
recently has been on this big anti-vaping kick, right? Because 6 people died or whatever, 500 people have aerosolized induced lung disease now from vaping. 400,000 people a year in the United States of America die from tobacco use. 400,000, and yet it's still available as a product on our shelves. 80,000 people a year die from secondhand smoke. They never smoked a cigarette in their life. They live with or are near someone that smokes. 80,000 people a year die from secondhand smoke in the United States of America in 2019. Actually 17, I think was last year, but we'll say close enough. So yes, it can affect that as well. We don't do that here. I mean, if you live with a smoker but you don't personally smoke, I'm not going to cancel your surgery.
Okay.
But it does have an effect. There's no question about it. It does have an effect.
Back to the injection, the hyaluronic.
HA, it's easier to say.
There you go. Easy for me. Easy for I am scheduled with you to have one in both knees.
Good problem tonight. You're giving a demonstration right here.
Oh, I got the knees and you got this. And we discussed this in your office, the difference in, and would you go over that again, please, and the difference in having the full shot in each knee or come back every week, 3 weeks?
So as Dr. Lawrence said, the 3-week injections in his hands and in my hands both, I think work better than the 1 shot. There are people that will do 1 shot because they can't stand needles. They have acute phobia of needles, they pass out. You're gonna get 1 injection, all right? There are people that live, literally I had a patient the other day that drove 178 miles to come see us. They lived over by Springfield or somewhere. I had to ask Drew where it was, I'm not from Missouri originally. If you're driving that far, probably gonna do 1 injection. If you live here in Cape, I'm gonna try my hardest to get you to get 3 of them. Sykeston, probably 3 of them as well, because in my personal experience, they work better. In Drew's experience, they work better. The literature says they work a little bit better. And I will tell you that you get stuck 3 times, but you only get 1/3 of the medicine. And when you put all of that medicine in 1 shot, it feels like somebody just took an elephant and blew their trunk in your nose. It's a lot of stuff and it's tight. And from a personal standpoint, it's hard to inject. It hurts my thumbs. Literally, that hurts my hands to inject them. It's so stiff and so
I would also just add to that, if you are going to have the 1-shot series, I would just recommend you get it image guided with either X-ray or ultrasound or something like that. It's a basically $1,000 shot. You want to make sure it's in the right spot.
Yes.
I've been to an orthopedic surgeon and for a hip replacement, and he has told me that if you're short, that it is more difficult and more risk involved. Do you agree with that?
That's a surgeon that doesn't do 100 a
Yeah.
year. I'm just gonna tell you right off the bat, Charity, you wanna take that
Is
any
that the
other way?
surgeon or the patient that's short?
Yeah, if the surgeon's short. Good point, Dr. Bones.
Well, no worries. None of us
If
are
Dr. Bones
short
stood
here.
up, you would understand the content of his answer versus my content of mine.
I will say, if you're extremely short, then like I said, sometimes you can lengthen someone's leg, and the implants, that can happen, but that's what that preoperative templating is actually designed to help avoid. But I wouldn't consider being short a risk factor, really, for that.
Would you recommend getting the surgery to get taller?
Only if we do both legs at once, I guess.
And they actually have special implants. We have one of our implant reps
Yes.
here tonight, but you know, if you are of Asian descent, for example, they are very small in structure and stature for the most part, and their bones are very tiny. And there are actually special Asian implants. So if you are really short, you know, if you're 4'6", we're going to have to custom order an implant for you or get one of the other implants brought in. But we can do it. It's not that. No. The answer is no. Yes. Back here in the back. Somebody that I met.
We have a question back here. This gentleman would like to know, if you have your knees replaced, how likely is it that you can get back to your activities you were doing before you injured the knee or developed the arthritis?
So were you playing professional football?
Motocross.
You can ride a motorcycle. I have patients that run, skydive, jump, climb, crawl, do anything they want to do with knee replacement. So depends on the knee replacement too, to be honest. There's different mechanics and different knee replacements. The companies have now come out with more natural knees. The old knees slid and rotated and set up more. Anyway, there's a whole section on biomechanics of this. But Zimmer, who's here tonight, has a knee called the Persona that is more anatomic. The Pew has one called the Attune. Nephew has the Journey. They're all more natural appearing, they're natural feeling. Patients typically that have a total hip forget they had a hip replacement, traditionally. Patients traditionally that had a knee replacement always knew they had a knee replacement. And if you look, there's graphs we can put up and charts and data, and we can go through all this stuff. But daily activities with knee replacement of the old designs, you always just felt a little bit off. You didn't quite feel right. The new designs, that's not true anymore. They actually feel like normal human motion. And I don't restrict my patients. You can do anything you want to after a hip or knee replacement. I don't care what it is. So climbing a volcano is probably not a good idea.
If we talk about just some of the more normal things we do in a day, I can tell you that time and time again, I've had patients after total knee, mostly like Dr. Jacobs said, total hips don't necessarily have to come to outpatient therapy. You might have a little bit of home health, but total knees, you're gonna come see me. And there's a lot of times people haven't done stairs in years because of their knee arthritis. You're going down the steps sideways or just avoiding them altogether. And so you have total knee, and we can get you back to doing stairs, and it won't hurt, and we're gonna strengthen you so that you can do that. I've had people who haven't done stairs in years, and they're able to go up and down steps, maybe holding on with one hand, maybe not even. So sometimes you get better than what you were before.
I'm going to take the prerogative and ask a loaded question here to one of my colleagues, because I think it's something y'all need to hear about. So Dr. Baker, I have a bad rotator cuff, and my shoulder has got pseudoparalysis, so I can't raise my arm up because my cuff isn't functioning right, but I really don't have a lot of arthritis, but I can't get my rotator cuff repaired. You just came out of Johns Hopkins. Are they doing anything cool and neat there, and are we going to have that soon that we can do with it here? What is that?
Yes,
This is really cool, guys, just so you know.
That's a great question. One of the newer technologies that's coming out is it's basically a spacer that you can help push the humeral head down. So when you have a big rotator cuff tear and you lose the stability of that joint, the humeral head actually elevates up. And that's part of that is why you can't have motion, is because you're just functionally acting very inefficiently. So hopefully in the next 2 years or so, they'll actually, the FDA will approve this device that we can put in arthroscopically, which is the video camera surgery, and it acts as a spacer to push that humeral head down to increase the efficiency of the other muscles that are still intact. And so that's something very exciting coming down the pathway.
Is it a permanent solution?
No, it's not. It's meant to essentially buy you time until you're ready for a bigger surgery like a joint replacement. But the results so far have been very promising.
It's one of the coolest things I've seen in orthopedics in a long time, and it was developed at Johns Hopkins where he does shoulder fellowships. That's why I asked him the loaded questions. Yes, sir.
Follow up on your stem cell. There was a number of years ago, I had back surgery, lower back surgery, and I went to St. Louis and had to go to different doctors for evaluations. But the similar point that I was thinking about was the fact that stem cells, as what you were saying, was comparable to a chymopapine injection way back. What was, and I didn't do it because I was scared to death of it. But I ended up with a microdiscectomy. But yeah, I had a doctor actually say he could do the injection and the possibility of relieving the pain and shrinking of the disc and doing all like that. I didn't know if that was even done anymore, if that was even, because that was kind of the rage 20 or 30 years ago, you know. And
so medicine's a business, right? Believe it or not, unfortunately, or fortunately, however you want to do your political stance, our medicine's a business. So there are lots of things that have a big flash and then burn out really quickly, like a firework. And there are other things like a bonfire that just burn and go on and on and on. Joint replacement has been going on and burning that bonfire for decades, and it works really, really well. Chymopapine, nobody does anymore. At the time, it was thought to be good. Turned out it wasn't. We're not perfect in medicine. We make mistakes. We develop things that we think look really good. They do limited testing. So the FDA, I've had to present to the FDA before for implants and things like that we've designed. And the process is so screwed up, I would not wish that on my worst enemy to go to the FDA. But you go through a trial process called an IDE, Investigation Device Exemption. You do the certain things. The thing Dr. Baker was just talking about is in the IDE study right now. And we may test it on 100 patients or 500 or 1,000, whatever, and it looks really, really good. And then we put it in the general population for whatever reason it doesn't work really well. There's a device called a Unispace here about 15, 20 years ago, brought out by a company called Orthopaedic. I put in probably 50 of them. It worked great in the trials. It just so happened they didn't have a great cohort of samples. They had mostly females in their trial. This device, I put in probably 50, like I said, 30 of them were females. All 30 of those females still have it, all 20 males, they all came out. So there's just things we can't predict everything. We're getting better because mega computers, supercomputers can do a lot of the simulation for us now. But there's still things we screw up from the design and development phase. So that was one of them.
Yeah.
Gentleman in the back had a question forever.
Yes, I heard you mention Sykeston a while ago. Do y'all come to Sykeston?
Well, he's from Sykeston, but we don't hold that against him. What's really fun is that we are also the team physicians for lots of the schools around here, including SEMO. But we also cover Jackson High School. Dr. Lawrence was the starting quarterback at Sykeston High School a few years ago, but we're covering Jackson, so he had to stand on the sideline with Jackson last weekend, wearing a Jackson hat when it was 45-0 at halftime over Sykeston. I haven't talked or teased him about that at all week long.
I brought the Lightning with me. I tried to get it canceled, but they just kept waiting and waiting.
No, we do not. Dr. Bowen will be down in Dexter in December, January. I'm not sure when he's actually going to start his outreach stuff. So he'll be down there. We've talked about doing a clinic in either Poplar Bluff or Dexter, but not Sykeston. That may be coming, it's just not on our radar. Yes.
You spoke to some degree about the stem cell philosophy, yay or nay. I haven't heard anything about cartilage for like knees. What's your take on that?
Cartilage for knees, what do you mean by that?
The cartilage procedure for knee replacement.
So I'm not even sure what you're asking.
Are you talking about something that they're doing at the University of Missouri?
Well, I have a relative that went through this with knee in St. Louis, and in the process, the surgeon punctured an artery.
So that had, number one, that would have nothing to do with whatever procedure they're doing. That can happen. It's very rare, but it can happen. When you talk about cartilage procedures for the knee, there is literally books written on cartilage surgery, but they are not necessarily alternatives to total joint replacement. Like, I'm doing a cartilage transplant tomorrow. I'm doing a cartilage transplant on Monday. Those are for athletes. Those are for young people. Those are if you have a hole in your cartilage that I can replace the size of my thumb. I can do a biological unicompartmental knee. If you have worn out one side of your knee and not the other and you're 30 years old, I'll take a cadaver bone and put it on the end of yours and replace your cartilage with that. If you have bone on bone and you're fit for your knee, you are not getting a cartilage procedure. There's a gentleman, I don't know if that's who she was involved in, at WashU. John Clohissy is up at WashU in St. Louis. He is one of the gurus of joint preservation surgery. So I'm doing one of those next week in hip arthroscopy, where I go in and shave extra bone off and do all that kind of stuff. So there are things we can do, but it is not an alternative joint replacement.
Thank you.
Okay. Sherry, did you have something about Missouri? I don't know what you're talking about over there.
They're doing, it's like it's an extended cartilage transfer that they're doing. It's called BioJoint. It is sort of actually geared towards those, but if you want to ask us questions about that, please ask after this conference.
In the back.
One more. I am 67 years old. If I get a knee replacement, will that be expected to last the rest of my life?
Yes, ma'am.
Okay.
I'm gonna make the Zimmer guy mad, but the FDA tells the companies what they can market and what they can't. All right. I've been in this business long enough. I've been in different companies and stuff, so I can tell you the FDA is just a disaster. They tell the company exactly what they can say, can't say, what they can market, what they can't market. The knee replacement that I designed is with a company called Smith & Nephew. All right, Smith & Nephew was smart because they had a former member of the FDA on their board of directors. So they went to the FDA early and said, hey, we've tested this knee. Can we say it lasts 30 years? FDA looked at the data and said, sure. Well, then all these other companies started filing protests, and the FDA realized they had opened Pandora's box. So there is one knee on the market right now that is marketed, approved by the FDA to say it lasts 30 years. And trust me, Smith & Nephew sells the you-know-what of it with that point. However, that's not because the other knees won't. The Persona from Zimmer, the Attune from Depew, they will most likely last 30 years as well anymore with the new technology. They just can't say it because the FDA won't let them. So, in all honesty, the new generation knee replacements, there's really not much difference between them all three. Four of them, I guess. Although Stryker's is
Stryker, I heard you say Stryker.
Yeah.
That's what I have in mind that's given me a fit. Not good, huh? Not good, huh?
Oh, it's not a bad knee, I just don't like the instruments.
Oh, okay.
I'm big on instrumentation, and I just don't like Stryker's instruments. The knee's fine, I just don't like the instruments.
Not if one of these knee implants came out was much better than the others, like I said, with like hip approaches, we would all switch. So we make these decisions based on how we train, what instrumentation that we're most comfortable with. There are plenty of reputable surgeons using Stryker implants.
Yeah, I know.
I just don't care for their instruments.
Yeah, I know.
Or somebody have one over here, yes, and then we'll come back to you, sir.
When you were talking, going back to the knee replacement again, we were talking earlier about what you do, like as far as to help with the pain afterwards, or, to cut the pain. These injections, I'm diabetic. So what do these do to my blood sugar?
After surgery, the injection I use, or before instead of surgery?
Well,
Like cortisone shots and HA
both.
shots, or after surgery?
Both.
So after surgery, there's no steroid in it, so it's not a problem. Sure, you want to talk about diabetics and injections?
Yeah, it depends on how well your diabetes is controlled, what your A1C is, what your daily sugars are. It's a transient elevation, it certainly is possible. It depends on how much injection we're putting, how much medicine we're putting in. For a knee injection, I typically put 80. In diabetics, I usually dose that down to 40 milligrams. Tell you to watch your sugars for 3 or 4 days. It's usually not a big deal, to be honest with you.
Oh, really? Now, see, I've had some steroid injections in the past that it took me like, I had to double my insulin.
Well, that's good information. If you're gonna get another steroid injection, so be sure to tell us that.
No, I did.
Remember when you call the office to ask for Dr. Lawrence?
I have an insulin pump, and I'd have to like double my
Yeah,
insulin
I mean,
for
again,
a week or
it's
more.
very, yeah, it's very individualized. It depends on your diabetes, if you have type 1 or type 2, if you're on insulin.
Type 1.
Well, that's actually a lot, yeah, most of the folks we're seeing are type 2, but a lot of type 1 also. But again, there's a lot of variability there. We'll be sure to hash that out before we do a steroid shot with you. If need be, I can work closely with your primary care doc. Again, I'm MMS trained, manage your insulin if we have, we can handle it.
Hyaluronic acid injections and PRP injections should not affect your blood sugar whatsoever, though. Yes, sir.
If you're looking at a revision surgery, knee surgery, do you replace it with the new and improved model, or do you match up the old one?
Depends on what you're doing. If you're just changing out, like the plastic part's warm, but the other parts are still fixed and your knee's working well, it's just wearing the plastic out, and we can see that. We don't want it to get where it's rubbing metal on metal. We'll just change the plastic and leave the other stuff in, but that's not super common anymore. Most of the time, by the time you come in to see us, that's too far gone, so we have to take everything out and put a new one in.
You were mentioning,
Over here in front, sir, I'm sorry.
Go ahead.
you were mentioning about tobacco as far as an absolute no after surgery. Is there other things that are absolute no's? What about bourbon or whiskey or?
For me?
I
For
mean,
me or
for you,
you?
it's okay, but for me, if I.
Depends if you share. If you share, it's fine. If you don't share, no. It's like kindergarten, you gotta bring it up for everybody.
But I mean, there's no problem with alcohol.
In minor doses, no.
No, you say tobacco is bad. Is there some other things that are bad? I mean, like sugar, or is there, I'm just curious.
Randy, you want to take that one too, from diabetics or a nutritional standpoint? Overall health is very important.
Yes.
Overall wellness is very important, but she's our nutritionist and she can talk about the dietary aspect after.
I think that the bottom line is, eating healthy, overall, and improving the quality, choosing nutrient-rich foods that will promote healing and all those good things. That's good for everybody, and we want, those are messages we would tell to the general population.
If you're struggling with your A1C, we certainly can do some more structured meal planning to help get that a little more controlled. So preoperatively, your numbers are lower. I think most surgeons are looking at an A1C under 7 as a goal. So if you know what yours has been or what you've been managing with the help of whoever's managing your diabetes and some modifications in your diet, we can get you there, no problem.
Just add anything in excess is probably bad. Most things in moderation are probably okay.
Let me just make a real quick comment. I had a sciatic nerve problem about 4 years ago. I couldn't stand up, couldn't even get out of bed. And they gave me Oxycontin. Didn't help at all.
That's
3
not
fingers
surprising.
of bourbon, I can sleep.
Also not surprising either.
Yeah, we're believers in moderation. So for alcohol, it's 2 drinks a day for men and 1 drink a day for women. But sometimes we have to define what a drink is. So that's a 12-ounce beer or 4 or 5 ounces of wine or 1 ounce of hard alcohol. So it's not a 22-ounce tall at Texas Roadhouse. That's not one. But anyway, yeah, everything in moderation, and definitely, one of the things about alcohol, it sometimes leads to excess eating. And so if you're working on getting healthier, alcohol can be the gateway drug for extra goodies.
I don't drink bourbon, so.
I'll say
He's a bourbon aficionado here.
from a post-op healing standpoint, we're worried about nicotine and out-of-control diabetes. Both of those things are shown to increase post-operative infections. Like I said, we really, really worry about infections because they're not easy to take care of in total joint replacements.
Yes.
Well, I have a couple of questions. One of them is about the postoperative infection. How do you tell if somebody has an infection?
Well, that depends on how far out they are from their total knee. If they're right after their total knee, a lot of times everybody who doesn't look at the total knee thinks that the total knee is infected if they see it 2 weeks afterwards because they're red and swollen and they're painful. If they continue to be painful post-operatively, like we're talking like months down the road, then there are some blood tests that we can do that look for inflammatory markers, but they're non-specific. So that could mean that you have an infection anywhere. That's usually my first step because it doesn't involve me sticking a needle in your knee. If I'm still worried about it, then the next thing is to aspirate fluid, and then there are several more tests that we can run on the fluid out of your knee to help us figure out what's going on.
And then another question I have is, like after a complete rotator cuff, surgery because it's complete tears. I know that physical therapy is really long, and if you're still seeing a lot of muscle weakness, would doing PRP or anything, would that help anything?
So the rotator cuff is a group of 4 tendons. And so it really depends upon how many of those tendons are torn, how long they've been torn for, how the muscle is before any attempt at surgery. And then those can predict how likely the repair will heal. Afterwards, you can have improvements in function and pain, even if you don't have the tear actually heal. So it's kind of hard to say definitively if any of those things would help. I do think that PRP does help improve that chance of it healing, but there's a lot of other factors that go into it.
And will an MRI or CT scan or something show if stuff is still torn or?
Yes.
Or an ultrasound.
Or an ultrasound.
So I just have another question. I'm also a physical therapist. You guys have been talking a lot about total joints. As far as trauma fractures go for either the hip or tibia plateau or ankle, I mean, do one of you specialize in that more than the other, or is it whoever's on call, or?
Yes. Dr. Baker does almost all of our proximal humerus fractures for us because he likes that. He loves ankles. I do a lot of wrist fractures. I do hand fractures. Charity and I do hip. All three of us do hip fractures. Charity and I did a big periprosthetic fracture together last 2 weeks ago. I got those x-rays and I can show you. But so yeah, we all have kind of our niches, but if there's something emergent, we all can handle all of it. But if it's, if you call the office and say, I've got this, then I might say, oh, I'll take that, or now would do that, or Charity would do that. So.
I was gonna actually make a comment Dr. Baker had. There are times when we can see things on ultrasound, and also we can do dynamic motion, which you can't do with an MRI. An MRI, you're lying there. So we can see what's happening to while you're doing that. But I have certainly had surgeons that have gone in and done work on a shoulder and looked for what looked like a rotator cuff tear. That was relatively small, but when they probe and everything, it seemed like the top part of the fibers were good. And they come back in and we'll ultrasound them and do a diagnostic injection with numbing medicine in that place, and you see their pain go away. So now we know where the pain is from. And that's the difficult part with the shoulder. Shoulder is 4 joints, multiple tendons. It has to work together as a unit. It's not one joint. And so the hardest part of it is determining what is causing the pain. If you're 50 years old and you've never had pain and we MRI you have a 40–50% chance of having an abnormal MRI. So it's always about finding the place. And so some of the things that Drew and I will do is diagnostic injections to find the pain source, to help them.
One last question. Okay, 2 more questions. 3 more questions.
I was curious about the timeline. Like I race motorcycles, very avid motorcycle rider. Also coach wrestling. If I have both knees replaced, both these shoulders replaced, how long am I going to be out of commission?
I'm gonna call tonight.
You want to have all of them done at once, or what?
Yeah, make me a robot.
Okay, well, I mean, from a bilateral knee perspective, like I said earlier, I would tend to try and talk you into doing one at a time, and I agree with Dr. McPherson that we can do those sort of sequentially. We just want to have you recover so that you do have a good leg to stand on after your total knees. There's always a conversation when you need shoulder replacements and lower extremity joint replacements about which one we need to do first, because if your shoulders are pretty bad, sometimes that can affect your ability to use a walker or a cane post-operatively. But if you want to have both shoulders done, I'm going to let Dr. Baker handle that.
So that is kind of tough. Unlike the knees and hips, the rehab from a shoulder is a little bit more prolonged. Typically I tell patients from a reverse it's about 3 to 6 months, for an anatomic it's about 6 to 9 months. And when you talk about timing, you also have to be careful about using walkers or canes immediately after a shoulder replacement. So one, I think it's important to figure out which joint is causing you the most problem. If the knee knees are significantly more painful, I would get those addressed first. If the shoulders are significantly more painful, then we can address those. Anticipate anywhere from 3 to 6 months from one side to the other side, and about 3 to 6 months before you would be using the walker or canes for the knee replacement.
As far as you're gonna need a hip replacement, is there a time of the year when you're booked solid, or does it matter what time of the year?
What are you doing tomorrow?
Everybody's
January is my open
deductible.
month, that's why I was just wondering.
No, it doesn't.
Never a problem?
Yeah, end of the year.
Drew and I are,
Because the deductibles are already paid.
end of the year does get a little busy sometimes, but Drew and I are the team docs that travel with football and stuff like that for Simone, so during football season for me is always a little crazy, so.
I'd say more so just getting into the office, getting to the office is not as more than surgery, so, and it's not terrible. I think I'm out a couple weeks, you're out maybe 2 or 3, 4 weeks.
Summer's actually our slow time because of the seasonal thing, the students are all gone, so we have a little bit less demand.
The best thing to do is to decide, you know, what's most important to you. If you want to golf every day, you know, you probably don't want to do it in March. If you're a farmer, you're not going to do it, you know, during harvest. So
I've got like
it depends a lot on, you know, when you would like to be out of commission.
I've got 9 or 10 totals already scheduled for the second week of November because they're all farmers. And we're just thinking that's when harvest is gonna be over.
Another thought is your deductible too, when you get out of the way at the beginning of the year.
I'm not doing anything tomorrow.
Last question.
I'm not doing anything tomorrow if you're available.
I got 6 cases tomorrow, you can be number 7, that's fine.
I called this morning and said you would be able to see me to the end of October. And I'm sure the pain's gonna be gone by then. Actually, it won't, because it's been getting worse in my knee as I go. Do I make an appointment with either of you, or Dr. Jacobs, or do I see Dr. Lawrence first?
Any of the 3 of us.
Okay.
Yeah, if you see Dr. Lawrence first, you just call the office and you're not sure this, that, or the other, and Dr. Lawrence sees you, or Dr. Bowman starts in December, sees you. If they think you're a surgical candidate, they'll patch it on to us, we schedule it. If not, they think your injections, they'll do your injections and take care of you up to the point of time you need surgery, and then hand you off to one of us.
As you can tell, we get along terribly. So if we ever have a patient that, you know, is in my clinic that I think is more appropriate for someone else, we don't hesitate to be like, this is something that's in your wheelhouse. So you can make an appointment with any of us.
One thing that we didn't mention is surgeons do like to wait 3 months after steroid injection before they do a joint replacement. So just keep that in mind.
I just wanted to make a quick comment. I've been fielding some questions in the back about supplements for osteoarthritis. Some people are interested in glucosamine, MSM, fish oils, and things like that. And I just wanted to share, first of all, supplements are an unregulated area of what consumers can buy. And so we're not always sure exactly what you're taking when you purchase that. I do believe there's some higher quality supplement companies out there, and I can certainly give recommendations. Glucosamine, MSM are both products that some people respond to. Typically not in severe osteoarthritis cases, though again, just like these folks have been sharing, in really kind of more mild cases, some people do respond saying that does improve. I don't know, some of it is anecdotal. We have very few good studies that support it. Fish oils have been found to be beneficial in rheumatoid arthritis. In certain people, again, smaller studies, we're not really sure. We love healthy eating and healthy body weights will help your joints equally as much, I believe. But those products, if you are taking them and you feel like they're helping you, they're not going to hurt anything. So you can feel comfortable going ahead and continuing them. If you're contemplating, whether I should have knee replacement surgery or start glucosamine, I think we're beyond the glucosamine point at that time, and we need to look at who we can get with to help with the physical therapy, strengthening, and then a surgical intervention if needed. But I've had a couple people ask me, and I want to just go ahead and address that. Thank you.
All right, everyone, thank you very much for coming out. We really appreciate it. Gwen, thank you for setting us up in the back. Gwen's our business development person at SoutheastHEALTH. Obviously, Brandon, thank you for chiming in here. Dr. Lawrence, thank you. Dr. Jacob, thank you. Dr. Baker, thank you. We're available. Obviously, y'all got our literature, because you can't show up at a Southeast Health event and not get bombarded with stuff from the hospital, because our marketing department's great and they like to spend money, so.
I'm also gonna apologize, I'm gonna run out because it's my wife's birthday, and I'm late for dinner, so I'm gonna go, so I'm sorry, I'm not gonna stick around for more questions, but thank you.
She's already texted me 4 times and asked where you were, so. All right, y'all, thank you again, appreciate it.
Thank you, have you been? See you too. So we're excited.